Good afternoon. This is a recording for the mental health review course. I hope that you all will understand. I'm going to do the voiceover. However, I'm going to convert it over to a YouTube so that I can make sure that it uploads correctly. If anyone have any questions, I'm going to post my number out there. You all can call me and let me know if you have any questions about the recording. We're going to be talking about therapeutic relationships. This is back to the basics of mental health. However, this is basically the goal in therapeutic relationship is to facilitate communication between you and the client. So it's going to be facilitating that communication of distressing thoughts and feelings. However, you're going to be assisting clients with problem solving skills to help facilitate their activity of daily living, and helping those mental health clients examine their self-defeating behaviors and also look at some methods of which can help them to adapt to their situation or their diagnosis or the disease. Also, therapeutic communication help promote self-care and also independence. So this is what we're looking to when we develop a therapeutic communication, not just with our mental health clients, but in clients in general. As we look at the phases of therapeutic versus non-therapeutic relationship, we look at, social relationship versus therapeutic relationships. And basically just to look at a few, as far as our social relationships, we don't make sure that the basic needs of the clients are met. Again, we have to make sure that the goals or the outcomes are mutually agreed upon. Also, the nurse also, it is our responsibility to maximize communication skills. Also, again, to help those clients to identify adaptive behaviors and change their maladaptive thoughts. Also, we also want to help the clients to enhance their own personal growth. We address those clients' needs. And then again, when we communicate with clients, we need to be straightforward. Not only do we need to focus on the client's ideas and again incorporate them to their plan of care. Behaviors, client behaviors, that we may encounter um, in the clinical setting. Again, some positive behaviors. We have to respect those clients, share information. Also, we have to include the family or the caregiver in the client's care. We also have to provide care that is compliant. Look at those, make sure the client is compliant. I'm sorry. Collaborate. And also, we have to make sure that we develop a trusting relationship. Clear boundaries for the client. Don't confuse them. Just set the goals or the outcomes, and then we have to set those boundaries, okay? Provide positive allowance, again, enhancing that therapeutic relationship. Some negative things, of course, on the other side would be disrespect. We don't share that information. So again, isolating. The client may isolate for themselves. Also, they may distrust the nurse. So they may also demonstrate a lack of clear and appropriate boundaries. Again, set limits, set boundaries, and hold the clients accountable, meaning that we can't allow a client to go and just disrupt an environment where it's going to impact the safety of that client or others. So we have to set boundaries as well. Also, as we look at therapeutic versus non-therapeutic relationships, we want to promote independence, not dependence. Focus on the client's problem, encourage behavioral changes. And again, the whole idea is to help assist those clients in alternative problem solving skills or developing new coping skills. We want to facilitate therapeutic communication. We don't want to provide information to the client that is blocking, that they don't have a clear understanding. And again, we want to promote not dependence. We want to promote independence. We don't want to focus on the nurse's need. We need to focus on the client need, and we don't want to enable those negative behaviors either. As we look at positive versus negative, again, these are some things here as we look at, we need to be consistent. We need to be, make the client needs to feel comfortable. Also, we also listening to the client. We need to listen and then make ourselves available as well to the clients. The nurse-patient relationship, we also, as nurses, it is we Empathy is temporary, living in another's life. So again, we want to show empathy. So not sympathy, but what? Empathy. We also need to provide that care that is genuine. A client can tell whether or not we are genuine. I make some examples, like if you walk into the room and the client is speaking to you, trying to tell you that their concerns, and you're looking at the one on your phone, they may assume that we're not providing care that is genuine. And also positive regards. Again, respect. Again, we have to respect the views of others and make sure that they, you know, view them as a worthy person, that self worthiness. Because if they don't have that self worthiness, then we kind of, degrade the client. Then again, they will have that low self esteem as well. We talked about transference and counter transference. We talked about that in class. I remember when I had you guys. So transference is basically a person unconsciously and inappropriately displacing or transferring their emotions uh, to another. So again, the patient may say, "You remind me of." You may remind me of my. They may tell you may remind them of their mother, their sister. So this is when the patient transfer their feelings onto the nurse. And then counter transference, on the other hand, is basically where the nurse kind of transfer feelings into the client. And again, you see this a lot sometimes, not a lot, but sometimes you may have a nurse that have just had some concerns or maybe some issues going on in his or her life, and then they may see a client that resembles them of some situations that have gone on in their life. So transference when the patient transfer their feelings onto to the nurse, and then counter transference when the nurse transfer his or her feelings onto the patient or the client. As we talk about interviewing, we have to, the foundation of interview, to gather our data, collect our assessment data, we have to interview the client. And so again, we make sure that we keep in mind their clients based on their culture. They may not provide eye contact. They may have specific body language, their vocal qualities. They may speak very low. So don't yell at the client. I can't hear you. Keep your voice at a minimum. Then verbal track, and I always kind of ask the client to, if there's something that you don't understand, always ask the client to explain it to you or repeat what they're saying. We don't make any assumption. So positive attitudes, attending to the client's need, open communication is going to be a key when you're doing your interview. Negative attending behavior inhibits impression. So again, we have to show those positive behaviors if we want the client to trust us and open up to us. The clinical interview, okay, like I said, the nurse also uses those communication skills, listening skills to better understand the patient situation. So you have to, sometimes it just takes just a matter of just sitting there listening to the client. It may not involve any conversation from you. The client may just want you to listen to them. The nurse also provides opportunities for the patient to reach specific goals. So again, make them feel comfortable. Make sure we, identify and explore problems related to the client. Discuss healthy ways of meeting their needs, their emotional needs. Okay, again, sometimes clients that may say, "Well, I don't have a I don't have a relationship." So we want to help them to establish a satisfying interpersonal relationship. Again, the interview process also, in order when we're preparing for the interview, we permit the patient to set the pace and let them start the conversation. In the setting, make sure that they feel secure. And seating, don't sit in a position where you kind of like staring at the client, face, just make sure they're comfortable. Also, make you introduce yourself, let them know who you are, and then again, let the client be the initiator. And sometimes if they don't say anything, we can offer leads, and making statements of acceptance. Do not, when the client say something to you, don't like reject the client or deny what they are saying. Just listening to the client and let them open up. Speak briefly. Who you don't know what to say, just don't say anything. When in doubt, you're gonna focus on feelings. You're gonna avoid giving advice. If it's me, I would do this. We don't want to do that. We also avoid relying on questions. So again, don't just keep asking a bunch of questions. Note the nonverbal cues that the client may be exhibiting. They may not say anything. They may be looking off into space. However, you want to keep your focus on the client, on the client. Uh, Now, that's basically covered the chapter on therapeutic communication. Now, I want to talk a little bit about anxiety. I'm going to talk about a few disorders that you will be tested on, and the ones that I'm covering on the PowerPoints are going to be the ones, and I'll refer you back to the chapters as well. But I've kind of pulled out that information that you need to be responsible for, or kind of as a refresher rather. So as we talk about anxiety, there are different levels. You have mild, moderate, severe, and panic, and then also sometimes clients their behaviors or characteristics sometimes they be perceived something that may never happen. They may be anxious about a situation that may never occur. Then again, um, there could be some physical or other characteristics that could attribute to anxiety levels as well. So again, as far as anxiety disorder, there are some comorbidities, a prevalence, high prevalence. Again, it could be anxiety could be related to depression, alcohol, drug abuse, eating disorders, bipolar, major depressive disorder. So these are some comorbidities that may also, occur in conjunction with anxiety. Client may also have some medical problems. IBS could be one, cancer, uh, you know, kidney or liver dysfunction, chronic anxiety associated with increased risk for cardiovascular mortality and morbidity. So again, these are all risk factors or comorbidities. Genetic anxiety could be genetic in nature. And again, it may interact with stressors, things that may be stressful to a client that may trigger an anxiety attack. So again, like I said, these are some comorbidities that you may see in conjunction with anxiety, or some things that may cause anxiety. As we look at the clinical picture, as we talk about those panic disorders, this is basically for the client, they may have a sudden onset of extreme apprehension. They may be scared or something, fearful. They may have a feeling of impending doom. Um, Terror is it's so severe that the normal function is suspended. They may have a panic attack. Physical symptom may be resemble that of a heart attack. Clients may say, I had a panic attack, felt like I was having a heart attack. Phobias. These are things that clients they have a fear of something. And social activities disorders are sad. They're like I said, generalized activity disorder. This is basically the expression of anxiety and worry about a normal events or activities. Symptoms may be conclude restlessness. The client may be fatigued, poor concentration, irritable, muscle tension. They may have problems sleeping. So these are just some clinical pictures. We're going to talk about different type of phobias. We talked about agoraphobia. I remember talking about that in class to you guys when I taught this course. These are some things, like I said, with panic disorders. These clients they have a fear of terror. This is where their normal functions kind of suspend. They kind of diminish or decrease. They become severely limited, have severely limited peripheral fields. They interpret the reality. They may have a certain onset of a certain occurrence of a panic attack. Again, with panic disorder, these clients have a high risk of suicidal attempt as well. And these some of the clinical manifestation or signs and symptoms that you may see. Again, they may have palpitation, chest pain, diaphoresis, tension, urinary frequency. They may be hyperventilating, breathing problem, nausea, feel like they're choking, chills, hot flashes. And like I said, GI problem. They sometimes the client again, some of these symptoms you can see are those symptoms that mimic cardiovascular disease or heart attack. Um, with panic disorder, sometimes they're rushed to the emergency department with signs and symptoms of a heart attack. Like I said, there's been an extensive workup on these clients for cardiac problems. Then again, they're basically everything kind of works out. So these patients need to be referred for potential diagnosis and treatment of anxiety. So if there's nothing clinically wrong with them from a physiological perspective, they would definitely need a psychological workup. Kind of mentioned acrophobia. This is where a client has intense anxiety levels of being in places, situations where it's very impossible for them to escape. So these clients sometimes they be antisocial because of the fact they don't want to they're afraid to like I said be around crowds. So again they have these big phobias. So again they fear places so they avoid them to help control that anxiety. Avoidance behavior can also be debilitating, life limiting constriction as well. Other specific phobias could be things like dogs, spiders, heights, storms, water, blood, close spaces. So these are just other specific phobias. SAD or social anxiety disorders is severe anxiety provoked by exposure to a social performance situation. Fear of saying something wrong. Sometimes people are very quiet. They don't like to speak out because they feel like they have a fear of something foolish, or they may answer the wrong question. Sometimes students don't. They don't want to say anything, and sometimes people have a fear of eating in front of others, performing on stage. They have fear again of public speaking. It's the most common one that they may fear. But again, it's all individualized. So that's anxiety, what I wanted to cover. So I'm going to be looking at the chapter on OCD. That's another content that we need to focus on. Obsession is unwanted, intrusive, persistent ideas that could be some thoughts, impulsive, or images that cause significant anxiety. And then compulsion itself is unwanted, ritualistic behaviors that the individual feels driven to perform to reduce that anxiety. And an example of that would be um, things like washing the hands, constantly. Or, I was reminded of a friend that she and her husband would go places together. So she had her specific route and he had his specific route. So again, they would each one of them would travel different routes going to the same place. So again, that they had that those were their rituals. They believed in that. So OCD behaviors, exist along the continuum. Normal individuals may experience mild to moderate obsessive behaviors, and then they may have more severe symptoms. So they with the OCD, they kind of focus on dirtiness, contamination, germs occurring, correspond with things like cleaning and washing hands, like I mentioned. However, the most severe form is through thoughts of sexuality, violence, and illness, and then death. So that's OCD. And some other diagnoses related to OCD, body dysmorphic. This is where a client has a preoccupation with images. Like they may feel like my nose is defective, or a defective part of their body. They're obsessed with that, thinking about the body. So body dysmorphic. Impaired or normal social activity related to academic or even occupational functioning. That's body dysmorphic. Then you have compulsive hoarding, excessive collection of items considered worthless. Okay. Again, individuals ashamed of failure to discard them. It can disrupt their life. Also, they become socially isolated because they don't want anyone to come into that, to see, to an environment to see what all they're holding on to. And then again, hoarding could also cause an unsafe living condition. Or they may have a lot of clutter. They may accidentally trip and fall due to all the clutter. So again, like I said, hoarding behavior with OCD, excessive collection of items. They don't want to get rid of them. And then you see this again, based on the literature, it could be genetic in nature. And again, that obsessive OCD and obsessive hoarding can also increase a client with comorbidities as well. So treatment for anxiety disorders, for the most part, going to be your antidepressant, your SSRIs, your also your tricyclic antidepressants and NAOIs. You need to know what those foods to avoid while taking those medications, MAOIs. Also, other medication may be your benzodiazepine, antihistamine, buspirone, anticonvulsant, antipsychotic medication. Okay. Also, complementary alternative medicine, also known as CAM. These are your plant-based substances that also could be used for anxiety. That your lavender oils and things of that such. So St. John warts. I'm sure y'all read about St. John warts, heard about it. You need to know that if clients they should not use this medication in conjunction with antidepressant. And there are a lot of side effects of St. John drug interaction rather. So clients need to be taught if they're taking any uh, alternative med, they need to notify their healthcare provider due to the drug interaction. That kava has multiple drug interaction. So again, they need to notify their healthcare provider if they're taking any of the kind of medicine. Now we want to talk about some neurocognitive disorder, and delirium is going to be the first one that I want to talk about. This is basically where a client has transit cognitive disorder, which usually it could be caused by some physiological disturbances, mild neurocognitive disorders, where a person is functioning at a lower level. Then you have your major neurocognitive disorders. Also, almost all aspects of the brain function are affected with the major neurocognitive disorders. Again, these when a client develops delirium, they may have problem with their memory. Also, um, functioning, that taking care of their basic needs as well. Delirium is always secondary to another condition. Always remember that. Some possible causes of delirium could be things like medical condition, substance use, intoxication, medication, or toxin exposure. Again, as far as delirium, these clients, like I said, they're going to have disturbance in their cognitive function, their thinking, their memory. They may become disoriented. They may have some impairment. Also, they may have what we call the sundown syndrome. And again, they may be okay functioning well during the day, but at night or later in the evening is when that delirium or confusion starts. It starts to develop. Okay. So, other types of delirium could be hyperactive. The client may be restless. They may be pacing. They become agitated. May have mood swings. Hypo, on the other hand, where they may be sluggish, drowsiness, maybe feel like they're in a daze. Or they can have mixed hypo versus hypoactive symptoms as well. So they can switch from one to the other. And then some signs and symptoms again of delirium. Again, they may have illusion where they have where they misinterpreted the sensory stimuli. They may have hallucination, visual, tactile, and then their physical needs. It's going to be your priority. So physical safety is priority for those clients with delirium. They may wander, they may fall. So again, safety is going to be a biggie. So we need to monitor these clients again. They again make sure we meet their physical needs and prevent them from injuring themselves. As far as mood and physical behavior, they may have mood change, of a dramatic fluctuation from again from happy to sad. So again, or confused or disoriented. So again, we need to make sure we monitor those clients' moods. Uh, there's some delirium assessment guidelines. Again, like I said, you want to ensure safety. You're going to gather history on these clients, information about their family and significant others. You'll perform a physical assessment also with a comprehensive uh, assessment looking at all and identifying any possible causes. And also, you want to assess the client needs for intervention to optimize comfort and orientation. Going to be a biggie. Some outcomes as far as our clients, we want them to be able to function at their highest level or pre-mobic level functioning, safety, prevent injuries, particularly in and out of the hospital. We wanted them to be able to be oriented to person, place, and time, free of falls and injury. And then again, sometimes clients become to have delirium, they pull up their NG tube. Again, IVs, oxygen. So we want them to remain, um, those tubes remain in place. Sometimes it may take restraints or medication. So these clients will pull out their tubings. Immediate medical interventions are very critical. So again, we need to determine what the cause of the problem. Then we want to prevent any permanent damages to the client. As far as these clients, they benefit from psychotics or anti-anxiety agents, but I'm sorry, they use very specific situation, but we want to make sure we use them infrequently because again, they can also cause the client to have confusion and disorientation. So again, we want to make sure to do everything we can without the medication to help control those clients' behaviors or the symptoms. As for safety, again, like I said, safety is going to be the key. You never want to leave the client um, alone um, when they're going through an episode of delirium. Visitors and friends must not be held accountable or responsible for sitting with the client there in the hospital. As for safety guidelines, well, the family was in there, they knew, but it's not the family responsibility. It's going to be the nurse responsibility. Uh, so again, if we're going to have someone to sit with the client, it needs to be somebody trained that either the facility is going to pay for, or sometimes the family pays for it themselves. But again, it's not the responsibility of the family once they become a patient in the hospital. So again, safety is going to be a big key for those clients that are having delirium symptoms or diagnoses. Some interventions, again, orientation is a biggie. Sensory stimulation, you're going to encourage the client in a meaningful conversation. Orient them to person, place, and time. And again, we may have to give them something for pain. Want to keep them comfortable. Again, we're going to get them up, get them, moving as soon as possible. Keep them moving. Again, if we're going to ambulate them, they may have to be ambulated with assistant. Again, with delirium clients, they may need oxygen, so assess their or do their O2 stat. They need adequate hydration and nutrition, so we're going to offer them fluids frequently. Again, make sure we ensure regular toileting. They may have to, we want to promote sleep and rest in a quiet environment. In those combative behavior, if the client says something to you that's degrading or insult, rather, I'm sorry, don't get upset with the client. Just understand it's it's their diagnosis. Because usually the client, I'm sure they wouldn't act out like that. Now we're going to talk about Alzheimer's. Um, uh, Most clients with Alzheimer's initially they're in a state of denial. They try to cover up. They fabricate, make up things, answers as they go. Again, they repeat words or behaviors over and over again. They avoid questions. They don't want to answer the question. Um, Cognitively, they may have amnesia or memory impairment, apraxia, aphasia, and agnosia. So these are some of the things we need to be assessing for in the class. So the four A's, okay? And then there are different stages of Alzheimer's. Stage one is when the client will start forgetting. They may have depression, possibly depression. Then again, stage two, they become confused. They have memory gaps. They would, kind of like have apraxia, labile moods. Also, stage three, they may have moderate to severe symptoms. They're unable to identify their familiar objects or people. So that's stage three. And then stage four is end stage, where they have agoraphasia. I'm sorry, they have apraxia. I'm sorry, I can't. This is kind of fine print for me. Apraxia. That's not apraxia. That's aphasia. They may also have becomes in a vegetative state as well. So again, they become very debilitated in that stage 4. This is the late stage. Some things that we need, some outcomes that we need to look for or assess the client for, and make sure we target those areas, make sure they don't hurt themselves, make sure we communicate, make sure we assess their agitation level, again, make sure they're comfortable. And also, Alzheimer's, it's a role strain for the family. So we need to make sure we provide resources for the family. Okay, the family needs have to be met. That caretaker. So again, our goal for this client planning, rather, we want to meet the client immediate needs, identify their level of functioning. Then again, like I said, assess the caregiver needs, provide realistic expectation. Let the client, family know this is stage 4. So be very realistic with these clients. And then again, you'll be able to identify those appropriate resources so we can link the family to those resources like respite care, things of that sort. So again, as far as we looking at some communication guidelines for those Alzheimer's patients, always identify yourself. Tell them who you are. Don't confuse the patient. Call the patient by his or her name. Speak slowly. Use short, simple words and phrases. Maintain face-to-face contact. And so don't be yelling across the room. Be near the patient when you're talking to them. So let them know that you're listening. And then again, you want to focus on one piece of information at a time. Don't bombard the client. Ask them about 3 or 4 run-on questions. Again, talk with the patient about their, familiar things. Encourage reminiscing about happy times. When the patient becomes delusional, you want to acknowledge that the patient is the feelings and also reinforce what? Reality. Don't argue or refuse delusion. If the client tended having some delusion, hallucination, don't argue. Don't refute it. Okay. Have the patient wear eyeglasses or hearing aids so they can see. If they have problems seeing, make sure they have their eyeglasses, hearing aids so they can hear. Keep the room well lit because again, we want to make sure the client don't fall and hurt themselves. Have clocks, calendars, and personal items, family pictures and Bible in clear view. Uh, Again, we're going to reorientate and reorientate. We're going to reinforce patient pictures, nonverbal gestures. Put marks on the calendar. Again, this is a method of orientating. We want a method to present reality. Don't ever try to confuse the client. If the client that with an Alzheimer's diagnosis get into an argument with another, separate the individuals. Again, explain your intervention. If they become verbally aggressive, then acknowledge the patient feeling, and you want to shift the subject to for more, something more familiar. I know this is upsetting for you because you always care for others. Kind of shift it, make them rethink, and then sometimes they regret, like, okay, they apologize. Because the Alzheimer's patient frequently create a heavy burden to the caregiver, like I said, you want to look at those community resources that assist the caregivers because, like I said, it become a burden to the family. And also, we want to talk to the family member about the progression of the disease. Let them know that it's very progressive and talk to them through each stage. Let them know what to expect. Um, there are 4 prescription drugs currently approved by FDA and for individuals with Alzheimer's. Your cholinesterase inhibitors, also your Namenda, another classification, Namethadone hydrochloride. Again, these are all been approved by your FDA. Um, Also, these with those kinds of Alzheimer's, they also have other coexisting issues. They may have depression. So again, as far as your SSRIs, that's another classification that can be used for these clients. The reason the SSRIs are used because they have lower side effects. They are well tolerated by those clients. Triazodone is one of your SSRIs that are used. It may cause sleep. drowsiness, and also it helps decrease agitation. With that being said, if they're going to be drowsy, they could be at injury, risk for injury. So you need to assess if they on this medication that actually get them to rise slowly because it could drop their blood pressure, and so again it could be at risk for injury. Other community resources other than one that I named could be Meals on Wheels, legal services, also support groups, and also adult daycare centers. Again, they're going to be contingent upon what stage the client is in, because if they are stage 3, it may not be a good idea for them to go to adult daycare centers. Suicidal ideation is the next topic that I want to talk about. It's a person thinking about self-harm. You want to always take an individual very seriously if someone mention that they're suicidal or have suicidal ideation. You always want to ask, are you thinking about harming yourself, killing yourself? Listen very closely to what the client is telling you and what they are not saying. So be very attentive to those cues. Some risk factors for suicidal, it could be related to mental health issues, other physiological issues, environmental, things like stress, bullying, loss of employment, divorce, exposure to suicidal, historically previous attempts, family history of suicidal as well. And then also there may be some adverse effects or event that occurred in childhood could have put a client at risk for suicidal also. Uh, Suicidal has been known to be genetic, and like I said, maybe due to societal factors. I mentioned psychological factors. Again, psychotic tendencies also increase the risk, especially those clients that are hearing having those command hallucinations. Again, I'm talking about killing themselves. Okay, client may feel hopeless, helpless, worthlessness. These are all could be some risk factors for suicide. Adolescent and young adults, again, the strongest risk factor. Usually you see this between ages 14 and 24. It could be related to drug abuse, behavior problems, depression, social isolation. Other factors, again, could be failure in school, difficulty dealing with sexual orientation, unplanned pregnancy. These are all examples of these clients. Sometimes they frequently run away from home. You may see that a lot among the adolescents. Um, Also, with kind of suicide, we always want to know what do you have a plan? And there may be just some behavior changes, which include giving away their prized object of possessions, writing farewell notes, making out a will, putting personal affairs in order, failing to sleep or falling asleep, more than one night in a row. So insomnia is a big sign, exhibiting suicidal unexpected improvement in mood. Again, they may be happy, going from being depressed to being happy. Okay. Also, another sign could be neglecting their personal hygiene. Okay, so these are all some clinical signs here. Some verbal cues that you may, clues, I'm sorry. Always take a suicidal threat very seriously. I can't take this anymore. Maybe an overt statement. Life isn't worth living anymore. I wish I was dead. Everyone would be better off if I was dead. Life is useless. Covert statements. It's okay now. Everything will be fine. I won't be a problem much longer. Nothing feels good. I never will again. I want to get my body to medical science. These could be some covert statements that the client may exhibit or demonstrate. Um, Again, there's some suicidal risk factors. Again, you want good assessment here. You always want to look at whether or not the client had a plan, any previous attempts, history, impulsive aggression. Again, hopelessness, and again, like I said, client has been incarcerated, and then peer pressure, chronic physical illness or pain could have put a client at risk for suicide. Uh, If you, as a nurse, feel concerned, always ask, are you thinking about harming yourself or killing yourself? It's okay to ask that question. You are also going to assess what precipitated these thoughts. Is there something difficult you're facing? Like I said, look at the risk factors. Family history. Do they have a plan? Red flags, again, like I said, suddenly going from sad and depressed to happy and peaceful. Often the decision to commit suicide gives a feeling of relief and calm. If the patient is to be managed on an outpatient basis, again, they need to be assessed for their social support. Do they have any support? Significant others with a knowledge of what to look for, those potential ideations. And then also your community crisis resources hotline. This is a modified sad person scale that can be used for suicidal potential. It's called the mad sad person scale, and we kind of talked about this also. That you rate the client. For instance, there's a male, they get a 1. Their age, if it's less than 19 or more than 45, they get another 1. So they kind of add up those points as you go. So no social support, that's a 1. So actually, you add those up. These are the guidelines for the action. Any score, if you get any scores between 6 and 8, it's probably going to require psychiatric consultation. More than 8, probably these clients going to have to be hospitalized. It could be voluntarily, meaning that they can go in on their own, or it could be involuntary, which is done by a court order. So again, look at that sad person scale risk for suicidal, and based on the scoring, it's going to be our clinical plan of action. And our clinical plan of action is going to be based upon that scale, the ratings. Intervention during the crisis period. Again, provide a safe environment. Document the client activity every 15 minutes. This is an institutional protocol on the inpatient basis. Now, we said document every 15 minutes, but if you see a question, say using the agency protocol or according to the healthcare provider orders, you want to go with that. But the key is that to document that safety, include what the patient is doing and with whom. Don't just say, what are they actually doing? Patient watching TV. You want to be very specific with these clients. You got to maintain adequate records of your activity and the physician activity. Again, these clients may have to be on one-on-one observation. Again, you can construct a verbal or written consent that the client will sign. I will not commit suicide. Have them to do that contract. Encourage them to talk about it, their feelings, and the alternative that they can think that they can cope with other than wanting to hurt themselves. Communication guidelines, like I said, during the suicidal crisis, we should be able to convey to the patient in all settings that the crisis is temporary. Uh, there's help available. You're not alone. Okay? So again, let them know that they have support. Intervention after the crisis period. You're going to arrange for the client to stay with family, like I said, in the hospital. If they're highly suicidal, you want to remove all weapons, all pills, and you want to activate social support. Encourage the client to talk freely, discuss those alternatives, and avoid decision. Contact family members, arrange for crisis counseling, and again, if a client is on medication, prescribe anti-anxiety or antidepressant medication if needed. You don't want to give them the whole bottle. You want to give them about 1 to 3 day supplies of medication should be given. With that being said, because the more medicine they have access to, they could be at a high risk for doing overdose. Okay, so this basically is the end of the review that I wanted to go over. Now I'm going to upload it. Like I said, you may see it as a YouTube video because I'm trying to get it uploaded as clearly as possible. And again, thank you for listening. If you have any questions, you can reach out to me and I'll be more than happy to assist you.